Okay, so we're going to do the second part of Airway. I skipped a few slides in there if you guys are counting the slides. It's just about OPAs and NPAs. So we're going to move into advanced airway placement. And this first part will apply to any kind of advanced airway that you might place, so anytime we say advanced airway, we mean a supraglottic or a subglottic airway. So one of the risks with these procedures is that the patient can desaturate, and this happens especially if it takes you a long time to get the tube into place because the whole time you're in there messing around, they're not getting oxygen. So one of the things that we do is apply passive oxygen, take an O2 cannula, put it on, um, turn it to the 6 or even higher, even though technically they go to 6. And then put the BVM over the top of that and continue with your breaths. The cannula is thin enough that it will usually just push into the tissue and you can still deliver effective breaths. Action secretions and prior with a BVM, you should always suction the mouth because if there's any liquid in the back of the throat and you provide a breath with the BVM, you're going to push that into the lungs. If your patient has a confirmed or you really highly suspected tension pneumothorax, you need to decompress that first, or you're not going to accomplish anything when you try to ventilate them because one lung is going to be essentially collapsed. Administering high concentration oxygen. This is if you weren't providing um, positive breaths to the patient, you would just put on a non-rebreather with 15 liters. If, however, you're probably going to be at the point that you're providing this is non-invasive positive pressure ventilation or oxygenation, which is the BVM, which you would have connected to 15 liters. And then you maintain PEEP, which you do this by applying a PEEP valve, will be a new device for us. And it's also a setting on a mechanical ventilator. Positive end expiratory pressure is kind of a back pressure against the lungs at the end of the breath out that helps keep the alveoli expanded so that they're more functional. One of the risks with advanced airway placement is hypotension. And there's two reasons for that. One of them can be the medications we give to sedate the patient so that they can tolerate the tube. And the other, keep on, it increases the intrathoracic pressure, pushing off against the inferior vena cava, which reduces the blood flow back to the heart, which of course reduces the blood flow out of the heart. So prior to intubation as well, you can consider, well, you should do bleeding control. If your patient is bleeding significantly, it doesn't matter if you only take 3 minutes to get the airway in, your patient lost a liter of blood in that time, and pretty soon you're going to be effectively ventilating a dead guy. Once again, decompression of the tension pneumo because the tension pneumo pushes off on the IVC as well, causing the same reduced blood flow to the heart issue. We can give IV fluids, which is a consideration, especially if your patient has a soft blood pressure to start with. And vasopressors for this scenario aren't really in our scope as an intermediate, but if any of you move on in your training, you will be trained how to use drugs to try to support the pressure. Okay, so endotracheal intubation, the most definitive technique for controlling airway in patients who are unable to maintain their airway. And this is because it goes into the lower airway and inflates with a cuff that completely seals off the airway so that you cannot have air going into the stomach or secretions going into the lungs. Indications for this, if you cannot ventilate the patient with a BLS airway, and we've discussed this, just because you have an ET tube doesn't mean you're going to put in an ET tube. But if you can't get the breaths to go in adequately, if you're unable to get a good face seal, if the patient has altered mental status like unresponsive with a head injury and is not able to protect their own airway, this is when there is an indication for an endotracheal intubation. We don't really know if that prolonged artificial ventilation is going to be needed. That's more of a decision that's made in the ER. But like I said, it makes the ventilation and oxygenation easier. prevents wasted ventilation and gastric insufflation. So even with like a King Airway or an iGel, there is still some air that can go into the stomach, and then that air is not getting into the lungs. Whereas if you're in an ET tube, every milliliter of air you squeeze through that BVM ends up in the lungs. There's also 5 medications that can be given through the endotracheal tube. You squirt the liquid into the top of the tube, and then you provide breaths with the BVM, and that disperses it into the lungs where it's absorbed. So this is a picture of an endotracheal tube. It's fairly flexible. It's open on both ends. The end to you has a 15 millimeter adapter, which is the same size as our BVMs. The end that goes into the patient is beveled, and then you can see here, this is like a deflated cuff. Once this entire piece of the tube has gone through the patient's vocal cords, you inflate that cuff via this port right here that you will have a 10 ml syringe attached to. And so now this cuff completely occludes the airway, preventing anything else from going down. They come in various sizes because you need to fit it to the person that you're putting it in. The most common sizes for an adult are between a 7 and a 9. It comes in whole and half numbers, so 7, 7.5, 8, 8.5. And you will kind of be able to see on the person how large of a cuff you need to use. The larger the diameter, internal diameter of the cuff, the more air you can move through with each breath. For pediatrics, you need to use a Broslow tape to determine the correct ET tube size because children from age 0 to 12 come in varied sizes. And on that Broslow tape, if you lay it out there, it will show you the correct size of cuff. Cuffs without a balloon aren't really used anymore. I don't know of a situation where we would, so we won't learn about those. Okay, so there's quite a bit of equipment that you have to have when you start this procedure. We're going to go through all of it. This is a laryngoscope. This is the blade that's used to displace the structures of the mouth so that you can visualize the cords. This is the handle that contains a battery pack, and then these blades have a light kind of right there. And when you lock them into the position on the handle, that light comes on and helps you see better into the back of the throat. These straight blades are called Miller blades, and these curved blades are called Mack blades. And the way to remember that is that the L for Miller is straight and the C for Mack is curved. And that's how all of us, I think, learned it. You also need a 10 ml syringe to inflate the balloon. You'll need suction equipment and water, KY jelly if the patient's mucosa are dry, because this can tear that delicate tissue in the back of the throat. It's kind of like the King Airway. We have it in there. If the patient's mouth is full of liquids that you're suctioning out, then there might be enough natural lubrication for inserting the ET tube. Continuing, you have to use either a stylet or a bougie to introduce this tube because it's just a piece of plastic that will bend off. So a stylet is metal and it can be bent. So you curve it, you put it through the ET tube, and then you kind of bend it so that it's in this curved position. The bougie is this long, flexible plastic. It's not a wire, but it feeds like a guide wire. You can see it's got kind of this little hockey puck ending in there, or hockey stick ending, and you can actually bend that to be even more bent. This looks like it sticks straight, but they're actually more flexible than that. You introduce that through the vocal cords, and then you thread the ET tube over the top of it, because once the bougie is between the cords, it's a guide wire basically, and now you know that your ET tube is also going into the correct place. The other thing that they suggest is having McGills. And the thing that I've used those for is if you see visible objects like a piece of food or a loose tooth in the back of the airway, you can use those to get it out. I have seen someone use one to pull the tongue out of the way, and it basically just ripped the guy's tongue. So please don't do that. Okay, so we have all our equipment assembled, and we're getting ready to intubate. But the thing is, we want to have our patient as good as possible before we start this process. So pre-oxygenating the patient, your goal is to have them at like a 98% if possible, so that if you have like a delayed 45 to 60 seconds without being able to give a breath, um, they have plenty of O2 circulating already. You probably shouldn't take 60 seconds to pass the tube. Probably should stop and go back to breaths if it's taking you that long to get the tube into place. With CPR, an ET tube is usually not indicated because it takes too long to get them in. But if you absolutely cannot oxygenate a patient in CPR and you've done 2 rounds with defib and you have not gotten ROSC, you will place an ET tube. The goal is no longer than 10 seconds for interruptions, which you probably can't get an ET tube in 10 seconds, but you will have everything absolutely ready and you will have the blade between the teeth of the mouth before they pause compressions. You get the tube in, inflate the cuff, and they will start compressions again because it's more important to have those high quality compressions circulating the blood. We don't need to be taking a long time to get this ET tube in. Otherwise, we've now resuscitated someone who has a hypoxic brain injury, and we have not done them any favors. Prior to using, you'll check all of your equipment. So like and we will practice this. You'll get your blade out and click it on to make sure the light works. You will check the balloon on your ET tube with your 10 mil syringe to make sure that it's inflates properly and that it's not torn. You want to have everything ready so that you can click through the steps of this as quickly and smoothly without any hiccups, because every time you have a hiccup, you delay the process. And you basically have to consider that your patient is essentially not breathing while you're in the process of doing this. So, I mean, if it helps you to hold your breath while you're practicing it, to realize how long it takes you, you need to realize the importance of doing this quickly and smoothly. So we use the blade, either the Miller or the straight blade, to pass to the back of the throat and then lift the tongue and the structures up out of the way. The Mac blade is designed to hook into the vallecula. Let's go ahead once here. So you can see here the curved blade comes down the tongue and then hooks into the vallecula. And then when you lift up, it pulls the epiglottis with it. The Miller blade is designed to go straight to the back of the throat, past the epiglottis, and when you lift up, you lift the structures with it. As far as a Miller versus a Mac, it's just user preference in an adult patient. In children, because of the difference in their anatomy, the Miller blade is used for infants and small children. This description of how to do this, there's another video on the YouTube channel that you really need to watch, because that guy does a great job of explaining it. But you put your blade in on the right side of the mouth, and then as you get to the back of the throat, you sweep the tongue to the left. The uvula is the little structure in the middle of the back of the throat and the pharynx, and that will let you know that you're in the center. You then lift up, and should be able to see the glottis and then the vocal cords. Cricoid pressure is when you have someone else push on the cricothyroid cartilage back towards the patient's neck very gently, and that will help move those vocal cords farther back, which might make them easier to see. So here's a drawing of what you will see when you visualize the vocal cords. Now this drawing here, this patient's vocal cords appear to be like on the top of their mouth. Sorry, they're not actually that easy to see. Here is a laryngoscope, like this laryngoscope with the camera view of a patient's vocal cords. So there's the epiglottis, and then the cords aren't like bright white, but they are a lighter color than the tissue surrounding them. And you can see here, as you see through the open cords, the tracheal rings in the front of the trachea. So you have to line them into the correct position. If they are a trauma patient and you can't use this, if you had to maintain C-spine, I feel like this would be a very difficult procedure. So he's talking about the different axes and how if they're just laying on the floor, you really are not lined up to be able to get in the mouth and around this corner and into the trachea. If you elevate the head of their head about 2.5 inches, that makes it a little bit better. It brings these two axes a little closer to each other. Um, this is effective for adequately oxygenating the patient with a BVM. However, you then need to tilt the head back to be able to get these two axes, is that how you say that? To line up to each other so that it's easier for you to introduce an ET tube through the mouth into the oropharynx and then into the trachea. So you'll position yourself above the patient's head. You should have already inspected the oral cavity for secretions and started and suctioned or removed them before you started providing breaths. Open the patient's mouth and then grasp the lower jaw and drop forward and upward. Keep in mind that if your patient does not have teeth, this might be very difficult to hang on to their mouth. They might be slippery. Also keep in mind that if your patient was unresponsive and it suddenly becomes responsive, your hand is in their mouth and they might bite you. You hold the laryngoscope in your left hand, insert the blade onto the right side of the mouth, displace the lung to the left, identify the epiglottis. This is a repeat. This just describes once again the two different methods depending on which blade you are using. This picture on the left, this yellow thing, which is funny because bougies are all blue, shows the introduction of a bougie introducer through the vocal cords and into the trachea. And you can see how this little kind of hockey stick end makes it so that as it comes down, it stays anterior and goes into the trachea and not the epiglottis. So if you either have the bougie and you introduce it first, or if you're doing the tube with the stylet, which is an all-in-one move, you visualize the cords. You have to watch the tube go through the cords, and then you want to advance it till the cuff is about 2 centimeters past the vocal cords. If you don't put it in far enough, you will be able to inflate the cuff, but it will be between the vocal cords and it will cause significant damage. You're going to inflate the cuff until you feel back pressure. And we'll kind of practice this where you squeeze a little balloon to make sure you've inflated it enough. And then you will, at this point, hold on to the tube with one hand, use the other hand to pull either the stylet or the bougie out of the ET tube. And you'll attach the BVM with the end-tidal monitor in place and confirm tube placement. Two ways we do that. The first one we do is we deliver breaths while someone else listens over the epigastrum and then on each lung. You should not hear any noise over the epigastrum. If you are in the esophagus, you'll audibly hear gurgling when you deliver that first breath. Sometimes, though, it's kind of hard to hear what's going on, so you listen at the epigastrum, then you listen on each lung, and you should hear equal lung sounds on each side. Once you've confirmed that you are in the right place, you will secure the tube with one of those Thomas tube holders, just like we use for the King. After you secure the tube, when you secure the tube, make a note of the marking where the tube is at the patient's gum or teeth. There's numbers on the side of that tube with little marks. So like 22 at the teeth is a common size or a common depth. Make a note of that and you secure it, and then you listen again to make sure, because as you're doing all the things, it's easy to move it in or out, especially in, because the balloon doesn't stop you from pushing it further into the airway. So once you know that it's in place, make a note of the measurement. Now your second confirmation is going to be using waveform capnography. These detectors that you see them referring to are a little kind of cap that we used to use more often, that went between the ET tube and the BVM and changed colors in the presence of CO2. They were like a one-time, yes, you're in the right place. They weren't ongoing monitoring. And so we just go straight to the ongoing monitoring. The other thing that you monitor is pulse oximetry, because presumably if you're in the right place and you're adequately ventilating now, you're adequately oxygenating. This is a video laryngoscope, and we will be getting one of these, and these just are a huge game changer. You're going to practice with the regular old-fashioned laryngoscope, but all of my live airways on like a human, not cadaver, were done with a VL, and that's really the only reason that I managed to get the tubes in. because there's a little camera at the end of it's got the same curved blade like a Mac. At the end, there's a camera screen, and then it shows up on this screen, and you can see so much better, especially if you have trouble like getting all of the structures out of the way. You get to see around that greater than 90-degree curve. It says it requires authorization for medical direction. It doesn't require additional authorization. Um, Casey has one of these, and so we will be getting one, but for the class, they are expensive. So we're having to ask the board to pay for it. But if Casey has one, we're getting one. That's pretty much how Carrie put it. And once you see them, you'll be much less intimidated by this procedure. I'm going to talk about blind intubation briefly. I don't know if it falls within our scope, but I can see in a super unusual situation where it would be needed. So we are going to discuss the process. So if the patient was entrapped, not breathing, you weren't able to get in there to provide adequate breaths, and you couldn't position yourself where you were, like they're still stuck in the cab of the truck. If the airway is completely blocked by blood or other secretions, which shouldn't be an issue because you should have adequate suction. Equipment failure. If all of your equipment failed and you did not have a way to use a laryngoscope, and then in disaster like a mass casualty incident where there's multiple victims and we only have one video laryngoscope or one regular laryngoscope and we have 4 people that need, like you get the picture of if you just had no other choice. So I'm going to show this, what they show here, how you're kind of reaching into the mouth, and the only thing you're using your fingers for is to guide, sort of keep the tube hooked towards the front of the front of the neck, so it goes into the trachea, and then also you will feel. So this right here is the deflated cuff. You have to just kind of feel once that goes past your fingers far enough that you know that you're through the cords, since you can't visualize it because you're not looking back there. So you get on the patient's left side. I guess if they're entrapped, you get on whatever side you can. You want to try to give them 100% oxygenation if possible. So you take a stylet and you bend, that stylet is bendable, and once you bend it, the bougie will bend itself kind of back, the stylet will not. So you hook it into a pretty good J loop so that it automatically goes around that curve at the back of the throat that's sort of a greater than 90-degree curve, so that you have it going where you want. Use your fingers to guide it, and then as you have your fingers in their mouth, you're going to feel the epiglottis, which you actually can reach back there and feel the epiglottis. And then you'll feel the cuff as it goes through your fingertips, and you'll move it, the 2 centimeters past that, well, probably 3 centimeters, and then you'll be in the right spot, and then the rest of the procedure will go the same. Okay, potential complications from these procedures. You can accidentally intubate the esophagus. You will immediately know because you will hear gurgling sounds when you listen over the epigastrum. The fix is to immediately deflate the cuff, remove the ET tube, provide breaths through a BVM, get your patient back to as stable as possible. While you're doing that, you need to evaluate what went wrong. You're going to try to intubate again, but you have to change something. So if you were using a stylet, maybe you'll try a bougie. If you were using a regular laryngoscope, you'll switch to the video laryngoscope. Some things you might switch providers. If you happen to be there with 2 advanced providers, you might say, okay, I missed, you're going to try next. Because if you just take the old cuff out and shove a new one, or take the old tube out and immediately shove it back in, you're probably just going to end up with the same result. Intubation of the bronchus is when we insert the ET tube too far and it goes past the bifurcation of the bronchi and goes into usually the right main stem. So you're going to only be oxygenating the right lung and not the left lung. This is an easy fix. You'll identify it when you deliver breaths and you hear lung sounds on the right but not the left. You'll deflate the cuff, withdraw it 3 centimeters, reinflate the cuff, deliver breaths, and at that point you should hear equal breath sounds. You can do damage to the tongue, the lips, or the teeth. We're very careful. You'll get you'll get commented on of get off the teeth if you're putting getting the laryngoscope on the teeth. It's the um, high acuity. It's just slow. I don't know how to say it. Cartilage that are on either side. I'm not sure where that stopped. Hmm. Um, you want to be careful that you have the ET tube in the center of the vocal cords and that you're moving it smoothly through the cords and not just jamming it and catching on a piece of tissue and just ripping it. You can damage the vocal cords. And then if you putting the tube and the blade into the back of the throat does hit the gag reflex, so there's a risk of the patient aspirating their sentence. They might be laying there unresponsive as far as you can tell, but awareness somewhere in their brain, something's going, which might cause them to release conversely, putting a blade to the back of the throat can cause a stimulation of the vagus nerve with increased intracranial pressure when we are putting something in the back of their throat. So a patient with a head injury can cause more damage by doing that. This is where it's very important for you to give a sedative to the patient to help reduce that. If you take too long to get the tube in, like we said, you're not giving them any oxygen, you're not giving them any breaths. So basically, they're not breathing the whole time you're in there. And I have seen doctors who couldn't get the tube and would not admit that they couldn't get the tube and kept trying and trying. And I've seen a patient get down to 30% O2 sat while the doctor was trying to get the ET tube in. That was many years ago because the mindset has now changed to once you drop below 90%, you stop, you back out, and you go back to BVM breaths. And then you resuscitate the patient back up to a great 90% or however high you can get them before you start again. Moves or is being moved like onto them displaced, which is why we make sure it's possible to become displaced. Someone needs to be to reassess it after movement to make sure moving, that's a good time for you to provide some. The cuff can rupture or they're inserting it, so it would be very rare for. But if the cuff tears, then exchange. You can't do this introducer through the existing tube, pull the existing tube out, leave the introducer in place, thread the new tube in over the introducer. So you don't have to worry about not getting it in the correct position. But it still is a matter of time, and during that time, the patient is not getting any breaths. So once again, they're going to drop their oxygen. We're going to stop this lecture here because the other two procedures are nasotracheal intubation and surgical airways, and neither one of those fall within the scope of an intermediate. So that will be the end of